Hi, my name is Clara Montanera and my topic of this video is antithrombotic therapy after acute coronary syndrome or PCI in atrial fibrillation. Definition: antithrombotic therapy is a fundamental treatment to prevent thrombotic complications and death in various cardiovascular disorders. Acute coronary syndrome is the result of an obstruction of a coronary artery, while PCI in atrial fibrillation is a procedure used to restore blood supply to the heart.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification. If you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.
Application in medicine. In an international trial, patients with atrial fibrillation who had an acute coronary syndrome or have undergone PCI receive a P2Y12 inhibitor, clopidogrel, and apixaban or vitamin K antagonist or aspirin or matching placebo for 6 months.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros. It has been proven that all antithrombotic therapy reduces the incidence of recurrence, ischemic events, and stent thrombosis. Cons. Are less effective in reducing the incidence of cardiac embolic stroke associated with atrial fibrillation.
Hello from Paris, EuroPCR 2019. My name is Davide Capodanno. I'm the editor of PCR Online, and today we discuss a hot topic. We discuss on how to manage the antithrombotic therapy in a patient with atrial fibrillation on oral anticoagulants who needs dual antiplatelet therapy. And I cannot really think of a better speaker for this topic of Dominic Angiolillo from Jacksonville, University of Florida. Welcome, Dominic.
Thanks for having me.
And I would like to keep this discussion very practical for our audience. So maybe I can take advantage of your presence and try to ask you very practical advices on how to manage this therapy. First of all, if the patient needs the anticoagulant, of course, because of AFib, which anticoagulant?
Well, there are no doubts in my mind that in the absence of contraindications, they should be on a NOAC. That is for sure. The question becomes which NOAC. On a personal note, I don't have a preference towards one agent versus another. If they already came in on an agent, I keep them on the same agent. I do not switch. If for whatever reason they're a patient on a vitamin K antagonist and do not have a contraindication, then I'll switch to a NOAC. But definitely, NOAC is the treatment of choice with full stroke prevention dose in line with the guidelines.
Oh, thank you so much. So the second logical question is, how about the P2Y12 inhibitor?
Yeah, so even there, I'm pretty firm on my choice, where clopidogrel is the P2Y12 inhibitor of choice. This is very consistent with guidelines both in the United States and in Europe. We have very limited data with the newer agents, prasugrel and ticagrelor. A little bit more data with ticagrelor, particularly from one of the trials, the redual trial. Those are recent analysis. I would say I would reserve the use of ticagrelor only for my patients at highest ischemic risk, but low bleeding risk. That has to be the condition, or for whatever reason, I know that the patient does not have a good response to clopidogrel.
Okay, so a NOAC first, then mostly clopidogrel with selected patients on ticagrelor. Now the maybe most difficult, at least for me, question is aspirin. For how long?
Great question. I think it's the It's obviously the million-dollar question that we've all been dealing with. A lot of differences in terms of recommendations in the United States and in Europe. I do believe now after the Augustus trial, we do have more convincing data that a strategy of dropping aspirin as soon as possible should be considered. Now, having said that, I still believe that for some patients, a brief period of aspirin, particularly for those patients at higher ischemic risk, should be considered. But I think the overall take-home message, we should be minimizing the duration of aspirin therapy.
So thanks a lot for these practical advices. It seems that we are going in that direction, and then we have still one trial to see on edoxaban, but yeah, maybe it's time to start thinking about dual therapy and then triple therapy for selected patients. Thank you, Dominic.
Thanks for having me.
Thanks a lot.
Thank you.
Issues in Ecuador. In Ecuador, the use of a direct inhibitor plus a P2Y12 receptor inhibitor without aspirin is considered the most appropriate strategy for a patient with atrial fibrillation, and vitamin K antagonists combined with an antiplaquetic agent are avoided to avoid blending.
So patients with atrial fibrillation have an increased risk of cardiac thromboembolism and need oral anticoagulation to manage that risk. But we have a challenge when a patient's had an acute coronary syndrome or needs percutaneous coronary intervention, because in those patients there's clear evidence base for dual antiplatelet therapy with aspirin and a P2Y12 inhibitor. And so there's an indication on the one hand for an oral anticoagulant and on the other hand for dual antiplatelet therapy. And so what we've tended to do is combine treatments into triple therapy. But the challenge here is that we know that incurs a high bleeding risk when we combine triple therapy. And what has been the gap in the evidence is knowing whether we can cut back, just use two agents to manage thrombotic risk, both the risk of cardiac thromboembolism and the risk of stent thrombosis or further coronary thrombosis. And so this is the real challenge that has led to a lot of uncertainty in the community as to what the best regimen of antithrombotic therapy is for which particular patient. There have been many large studies that have looked at the role of non-vitamin K antagonist oral anticoagulants. We've got a number of agents now, apixaban, rivaroxaban, dabigatran, edoxaban, and these agents have all in their large phase 3 trials shown superior safety compared to vitamin K antagonists, predominantly warfarin. And particularly there's a lower risk of intracranial hemorrhage with the NOACs compared to the vitamin K antagonists. And this has led to increasing adoption of these new agents, which have some advantages also in terms of not needing regular monitoring of coagulation in order to set a dose. The doses are determined according to renal function and other clinical characteristics. But most patients, the majority of AF patients, requiring a single dose of these NOACs in order to achieve superiority compared to agents such as warfarin.
Conclusion. In patients with atrial fibrillation and result acute coronary syndrome or PCI treated with a P2Y12 inhibitor and antithrombotic regimen that include apixaban without aspirin result in less bleeding and fewer hospitalizations, without significant difference in the incidence of ischemic event that regimen that include vitamin K antagonist, aspirin, or both.
Well, for atrial fibrillation patients, sometimes they will need to undergo PCI, and that mixture of the two diseases together has been a difficult problem to manage in that we need anticoagulation for the atrial fibrillation and for PCI with a stent, dual antiplatelet therapy. And the triple therapy that results of both those together has a very high bleeding risk. And so we've been searching for how to reduce that, and the WOOST trial had suggested you could reduce aspirin and have less bleeding and still be okay on thrombotic events. But it was a modest-sized trial, so we were all looking for more evidence. And then could that be done with a novel oral anticoagulant? And so that's what we tried to address in the REDUAL PCI study. So the trial looked at patients who all had atrial fibrillation, thus anticoagulation indication, had undergone a successful PCI, and on average they were randomized at 1.1 days later to different strategies. And 2 of the 3 were a dual antithrombotic strategy, and they used the 2 approved doses of dabigatran, the 110 and the 150 milligram twice a day dose. So that plus a P2Y12 inhibitor. And we allowed clopidogrel or ticagrelor actually, in there. And then the control arm was warfarin, clopidogrel or ticagrelor, and aspirin, although the aspirin, in large part with WOOST, we already shortened the duration of the triple therapy because that's what was being done in practice to just 1 month following bare metal stenting and 3 months after drug-eluting stent. And so then the rest of it was warfarin double therapy versus dabigatran double therapy. But the concept really to look at whether one could safely withdraw aspirin and use a novel agent. We were delighted to see for our primary endpoint of ISTH to find major or clinically relevant non-major bleeding that there were reductions in both dabigatran dual therapy approaches. And so we looked initially for non-inferiority that we saw, but there was actually significant reductions in bleeding. So at the 110 dual therapy approach, it was about a 50% lower risk of bleeding. And even at the 150 milligram dose, but in this dual strategy approach, it was 28% lower risk of bleeding. So
Thank you for watching my video.